Good evening, everyone. Thank you for joining today's Fireside Chat number 203. Today we have Prof Rasha Darwish from Egypt, and she'll be taking us through exploring the psychological dimensions of dialysis. But before we give her the mic, I would very briefly like to introduce her, though this introduction doesn't do justice to what she has in the background, but this is what I was told to do, so I'm doing so. So Prof Rasha is a consultant of internal medicine and nephrology in Cairo, at Cairo University. She's a treasurer for AFRAN. She's also the committee chair for AFRAN. She is also part of the ISN Dialysis Working Group as deputy chair. She's also the ISPD nominating committee member representing Middle East and Africa, and she's also Strong Kidneys Task Force for ERA member representing Africa. So with that very brief introduction, Prof Rasha, this is your floor. Please, you can proceed. Thank you.
Thank you so much, Dr. Mazhar, for having me with Africa Health Network. It's always a pleasure to participate in your very regular educational activities. And I want to welcome Prof. Sarala, who is among us, who is our mentor and role model. Today, I'll be talking about a topic which is, I believe, is very important, which is psychology and dialysis. My talk will be covering these specific points. I'll be giving an introduction. And then what are the psychological issues in dialysis and the contributing factors? What is the management and potential psychological interventions we can provide to these patients? And finally, recommendations and conclusions. My introduction first, I will start with the numbers. Numbers speak. We all know that the burden of end-stage kidney disease is growing globally, and it's estimated to be around 13.4%. And in this very strong consensus that I'm sure all of you have seen, that they are stating that CKD, in contrast actually to cardiovascular diseases, stroke and respiratory diseases, the prevalence of CKD and mortality has been rising. In contrast actually to chronic lung disease, where the presence or the prevalence has diminished, stroke have diminished globally, heart disease. What have been increasing is actually cancer, diabetes, and CKD. And it is even estimated that it's going to be even more than diabetes. So currently, the kidney disease is the third fastest growing cause of death globally, and the only non-communicable disease which is exhibit a continued rise in age-adjusted mortality. It's expected it's going to even be more than diabetes in 2040. So we have a high prevalence of CKD. It was in 2010 about 2.6 million individuals receiving kidney replacement therapy, but it's currently estimated to reach up to 7 million individuals. Also, we have an increasing mortality in CKD. As you can see, the forecast increase in years lost between 2016 and 2040, that we have an increase, a 100% increase in the number of premature deaths with CKD. Well, so what is bad that we have an increasing mortality? When you see that just being on dialysis, you can, at the age of 40, has the same life expectancy than a patient who is 75 years old. So it is deadly and they die younger. Also, CKD is expensive. Dialysis is expensive. I mean, if you look at the healthcare cost, in 2024, they estimated that the average annual salary in the USA was about $60,000 US. Well, actually, this is exactly the cost of hemodialysis per year. So CKD and dialysis has a very high financial burden. And what do we do when we have a patient who has end-stage kidney disease? The most common way or form of renal replacement is hemodialysis. Actually, globally, around 69% of all kidney replacement therapy are done via hemodialysis, and 89% in general hemodialysis. So 69% dialysis, but 89% hemodialysis. And is it effective? Well, even in high-income countries, 15 to 20% of patients die within 12 months of starting dialysis. So what is happening in dialysis? What are the dialysis consequences? We all know that in general, it is said that it has biological consequences, and we have seen all the time, and we are seeing all the time, many studies covering these biological consequences. We also have several studies also discussing and trying to understand more the social consequences of dialysis. But unfortunately, psychological consequences, very few studies are available until our current day. And if you look at the hierarchy or the triangle of the importance of the hemodialysis outcomes to the patients, caregivers, and clinicians, always the peak of the pyramid, which has clinical importance, is fatigue, mortality, vascular access, and cardiovascular disease. But despite the many advances that we are supposed to see now in hemodialysis technology, the outcomes are very, very still poor for the patients, and it remains a major public health concern. So that's why now there is an increasing importance to the other actually outcomes of dialysis. And if we look at the rest of these factors, you can see that depression is present, ability to work, impact on family, ability to travel, cognition, anxiety and stress, food enjoyment, sleep, sexual function. All of these are actually part of the psychological disturbances which is happening to the hemodialysis patients, and still very few studies are tackling these very vital issues. One of these studies, which was done by the ISN, was trying to see if to compare between an adult reporting no chronic kidney disease in general. Is he complaining the past year of any mental illness? Well, only 17% complained of that, with only 4% reporting a past year serious mental illness. But if someone is having hypertension and diabetes, the reporting of a mental illness in the past year raises to 20%, with 5% a presence of a serious illness in the past year. But patients with CKD, 27% of them reported a past year and any mental illness. So we have the CKD patients are the highest in comparison to others reporting mental illnesses. This very interesting study, which was done on a relatively small number of patients, when they looked at the medical comorbidities of these patients, we can see that the percentage, as we know, of developing or having diabetes, hypertension, etc., are within specific range, as you see. But if you look at this study, when they look at the psychiatric comorbidities, 75% of the same patients reported having psychiatric comorbidities, with more than 56% reporting depression, 51% anxiety disorders, and 7% panic attacks. So, psychiatric disorders were found to be actually associated with poor prognosis and high mortality in end-stage renal disease treated with hemodialysis. So we see the magnitude of the problem and actually the magnitude of the outcome of this problem. So what are these psychological issues in dialysis, and what are the contributing factors? Well, why this is happening? Because the patient who actually lost his kidney is mourning multiple losses. He's losing, of course, we know the renal function, but he's also losing his role within the family, his role within the workplace, his physical skills, and sometimes even his mobility, his cognitive abilities, sexual function, and many others. So understand why this could actually cause psychological issues in these patients. And that's why it's very important that actually before the patient starts dialysis, when he follows up in the clinics in the late stages of CKD, that we have a proper preparation for the transition to hemodialysis. This is vital. Otherwise, many of them actually refuse the idea of dialysis due to the fear and the depression which is associated. Let's look into details. Actually, in the process leading to end-stage renal disease, the patients have different progressive irregularities, which are mainly emotional, metabolic, and hormonal. This increases their psychological burdens, and this leads to many actually abnormalities. This leads to decreased quality of life, depression, cognitive dysfunction, fatigue, anxiety, sleep disorders, and sexual dysfunction. And let's look at each one of these in detail. First, quality of life. We know that the definition, the perception of the individual's position in life, and it is within the context of their culture, value system, relationship to life goals, expectations, standards, and others. And we all are hearing many talks about quality of life because it is found to be a very important factor in the assessment of the management of these patients. What happens in dialysis is that these patients spend a lot of time and there are lots of physical demands to dialysis, and this results very clearly in a diminution of the quality of life of these patients. In this meta-analysis on 200,000 patients trying to assess quality of life in CKD, especially those on dialysis, when they used the health survey F36, which is actually a survey to estimate quality of life, the score was 36 out of 100 when it is evaluated to be normal when it is above 50. So the score was very low as quality of life to dialysis patients. And to go further in this, also the same study, they were trying to look at the relation between the socio-demographic data and the quality of life in these patients. And what they found was interesting, that actually the quality of life in dialysis patients when they are single is better than if they are married. What was their justification is that single, they have less responsibilities toward their families, so usually it is better for them. But married was actually better than widowed and divorced. Why? Because we know that married, widowed, and divorced, they have more actually duties, especially if they are widowed and divorced, the duty they cannot meet, and it presents a bigger burden affecting their quality of life. Also, what was interesting is that university-educated patients had a better quality of life than low-educated. Justifications? Well, when you are educated, you are equipped to create a more satisfactory environment with better health services and finances. They can pay for themselves, which provides a better solution for their condition. And also, it was found that higher education, it helps in raising the awareness of the disease and increases the ability to cope with the chronic disease. So educated dealt better with their disease and dialysis than non-educated. And common sense employed were much better than unemployed. And why? Because when you are employed, you have a daily activity, work capacity. Of course, it improves the quality of life. And when you hold a job, it has a positive influence in the individual because he still has a role in the society, and it improves their self-esteem. So this was a very interesting facts regarding patients on dialysis. What about depression? Well, according to this paper, patients on dialysis experience depression 4 times more than the general population. Actually, it was found that it's the most common psychiatric abnormality in patients on hemodialysis. Why? Many factors were presented: stressors, cognitive impairment, and biochemical changes happening in these patients. Stressors, well, we just have to say that our patients, they are relying on a machine to survive. So of course it impacts their sense of control. They cannot control their dietary and time. They have functional limitations. They loss of employment, changes in their self-perception. Who am I? Who is this person on this machine? Alterations in their sexual functions. Also the general perceived effect of illness in general. The high pill burden to treat the illness. They're taking so many medications for so many comorbidities. And expenses, the worries, the uncertainty and the anxiety while they are waiting for a transplant, or even worse, where they are fearing death. So you can imagine all the stressors these patients are dealing with. So again, that's why we have a very high rate of depression in dialysis patients in comparison to other chronic diseases. Also, these patients, as I'm going to explain later, many of them have cognitive impairment. And you can imagine that if this person doesn't know where he is, or forgets things, or has impairment in his cognitive abilities, of course he will develop depression. And then there are biochemical changes happening in dialysis patients which actually could lead to depression. Some of them are simply gender factor, because simply by being a female, in this study, as it is shown, females have higher rates of depression and anxiety because of hormonal factors and structural factors, and also because they have negative emotions more frequently, and they immerse themselves in these negative emotions, where in comparison to men who actually digest the depressive emotions better. So hormonal factors are playing, but also social factors, social status, cultural constraints, because females have lots of responsibilities toward their families, and they find themselves in the concept of dialysis not able to provide these responsibilities, which actually increases more the depression, and also poor sleep quality, which was reported more in females. Then other factors, biochemical changes, were actually the immunity changes which happens, we all know, during dialysis. And these changes in the immunity, having an immune dysfunction, actually decreases the cellular immunity, and also it causes them to have more infections, which is also always a burden on these patients. It was also proven that many of our dialysis patients have increased inflammatory cytokines, interleukin-1, 6, and tumor necrosing factor. And all these inflammatory cytokines were found to be much higher in patients on dialysis. What does it cause? Actually, it was found that these stimulate the hypothalamic pituitary adrenal axis, and these actually induces serotonin dysfunction and hypercortisolemia. So all of these actually are organic causes of depression in these patients. Thus, it increases depression and mortality. There is also a very important factor to depression, which is actually malnutrition. What was found that a lot of studies have found that depression is related to low body fat, hypoproteinemia, and anemia that we all know is frequently associated and present in patients on dialysis. And also it was found that patients who have malnutrition and inflammation, the two that I've just mentioned, malnutrition plus inflammation, actually cause vascular calcification and atherosclerosis syndrome. And if this happens, in particular, in the frontal subcortical limbal pathway, this affects the mood. So many of these biochemical changes organically changes the brain of the patient on dialysis, increasing his chance, or the percentage of him having depression. And on the other side, as we know that we have a vice versa effect, that depression also by itself causes loss of appetite and poor food intake. So it is a kind of a vicious circle regarding depression and malnutrition. So what are the impacts of depression? What does it happen? Actually, depression, as I mentioned, will cause malnutrition. Also, depression can affect the sleep of the patient. It increases the likelihood of cardiovascular disease and infections. It can, of course, complicate treatment compliance. Patients who are depressed might skip dialysis sessions, might skip treatment, and affect the outcomes. And thus, accordingly, it increases the risk of hospitalization. At the end, depression just provides a very poor prognosis and high mortality. So we have a vicious circle between CKD and depression, with depression, CKD causing depression, and depression worsening the general condition of CKD and dialysis. Another point which is very important is a cognitive dysfunction, which is also frequently associated in patients on dialysis, that actually I mentioned as being one of the causes of depression. Why? A lot of patients actually have a higher risk of having vascular diseases, which organically might cause cognitive dysfunction. In this actually large multicenter study, up to 71% of the 676 patients had cognitive problems in this study. And in another 2015 systematic review, where 3,522 patients, all the patients on hemodialysis had worse cognition than the general population, especially in the domains of orientation, attention, and executive function. So now I was talking about cognitive dysfunction, and I said that vascular disease could be actually the reason behind these patients having cognitive dysfunction. And it was found that patients had more chance of developing it if they had general risk factors like anyone else, whether they're on dialysis or not, like aging, patients having hypertension, having diabetes, dyslipidemia, etc. But actually, we all know that many of our patients on hemodialysis have these general risk factors. So this increases further the chance of having cognitive dysfunction. But we have actually risk factors which are secondary to hemodialysis therapy in general, which is actually hypoxemia, hypercoagulability. We have fluctuations in volume status in between the dialysis sessions, the presence of uremic toxins, and of course, metabolic CKD and BD with all the calcification of the vascular system, and the inflammation with end-stage renal disease. So all of these factors actually increases the chance of having cognitive dysfunction. And despite us knowing all these factors, it was found that even the patients who were maintained on an adequate dialysis dose and avoided intradialytic hypotension, we had no actually better improvement in the cognitive dysfunction. So that's why we really need more frequent trials to approach this very, very sensitive complication of dialysis. What about fatigue? We all know that this complaint is so frequent in dialysis patients. What is it? It's a subjective, complex, and multidimensional experience that encompasses both physical and psychological domains. It can be even considered as a continuum between energy and vitality in the side and exhaustion and tiredness at the end. And we also have seen these very, very important pyramids showing fatigue on the top of the clinical importance in dialysis patients. But it was found that why? Because the prevalence is so high, from 60 to 90% of patients on dialysis complain actually of fatigue. And again, when they use the SF36 questionnaire, which is trying to assess the fatigue, well, it was found that actually the results were very, very high, and many patients were complaining of it. And although many factors were associated with fatigue, but the exact etiology of the fatigue is really unknown. But they are trying to explain it that maybe fatigue is due to social demographic factors like age, gender, race, or social support. Maybe due to clinical reasons like type of replacement, renal replacement therapy, comorbidities, the KCRV, or biochemical and hematological factors like CRP, interleukin 6, malnutrition, hemoglobin. And as I mentioned before, psychological. I mean, if a person is having depression or cognitive abnormality, sleep disorders, of course, this patient will complain of fatigue. But what was proposed as a potential pathophysiology behind the fatigue was mainly inflammation. It was proposed that, as we have mentioned before, that patients on dialysis have higher levels of interleukin 6 and CRP, and that these directly could affect the adrenal glands and also affect the central nervous system, in particular hypothalamus and pituitary, maybe causing a direct effect and being behind the fatigue complaint of the patients. Or indirectly, as I've mentioned, by including, because these patients have depression, sleep disorders, and anxiety, which of course could result in these patients complaining more of fatigue. Usually, it's more severe on dialysis days, as we all know. And lots of studies showed that fatigue in patients receiving hemodialysis is associated with reduced sleep quality, so it's a vice versa relationship, poor quality of life, of course, increased cardiovascular disease, increased hospitalization, and increased all-cause mortality. How to manage fatigue? Well, actually, there is no specific treatment strategies to deal with this fatigue on dialysis yet. There are suggestions. I mean, they have said that maybe the anemia, the lactic acidosis, or the protein energy wasting and sarcopenia, if you try to deal with them with pharmacological interventions like growth hormone, steroids, vitamins, alkalinization, or APO, maybe it could improve the fatigue. But even the data and the studies, they remain conflicting and they are really inconclusive. But what was more or less actually proved to be effective are the non-pharmacological interventions, which is actually regular physical exercise. As you can see in the drawing, it was found that in particular intradialytic cardiovascular exercise reduced inflammation and improved physical performance and diminished fatigue. As you can see, that cycling during hemodialysis prevented in this study further fatigue buildup, and it was even better than actually pharmaceutical intervention. Also, it was found that if you have, due to exercise, it increased the peak VO2 between 20 to 40% following the exercise. Also, better sleep was reported in these patients who did exercise. So maybe the better sleep was an indirect effect which diminished the fatigue in this patient. They had also reduced depression due to the positive effect on the mood by the exercise. And it was found that in particular, in this study, if you join actually an aerobic exercise, like actually intradiabetic bedside cycling with some also resistant, it improved markedly the quality of life and reduced fatigue. So what we can say, that still we need larger trials, because still fatigue is a big mystery in hemodialysis and need to be addressed more seriously in our patients. What about anxiety? Well, again, in this systematic review, it was found to we have a very high prevalence of anxiety in our patients, up to 42%. It was also found to be associated with especially depression. So depression and anxiety are usually together. Also increased length of hospitalization. The more patients stays in hospitals, ICUs, of course, they have more anxiety. And as a consequence, they have a decreased quality of life perception. The underlying mechanisms which were postulated behind anxiety, again, of course, stressors that we have mentioned, or actually it was found that maybe organic reasons like uremic toxins or oxidative stress or cerebrovascular damage were found to maybe play a role in anxiety, and even the renin-angiotensin-aldosterone system activation was proposed as a mechanism behind the very high rate of anxiety in our patients. But what's positive is that they found in this study that a brief cognitive behavioral therapy intervention only after a 4-week follow-up actually approved the patient. They decreased the anxiety, they decreased the depressive symptoms, and improved quality of life. So this is something very simple, which was tried. Maybe we should try it more in our dialysis units, and it might actually improve the anxiety levels of our patients. What about sleep disorders? Well, in these actually 12 studies from 10 countries, they found that actually the prevalence of poor sleep was up to 69%. And of course, when they did again this SF36 questionnaire, the prevalence of poor sleep quality, it was very, very bad. The score was less actually than 5. So what we know that actually sleep disorders, they are an independent association between poor sleep and decreased quality of life, increased risk of cardiovascular diseases, and actually increased mortalities. Can you imagine that just the patient not being able to sleep, which seems a very trivial complaint, could actually lead to an increased mortality in our patients? So it's very important to try to identify what are the underpinning factors. And it was suggested that, of course, they have depression and anxiety. It might affect their sleep. And there are physical reasons which might stop their proper sleep, having cramps, having pain, the restless leg syndrome, the pruritus, which can kill the patient. The chronic pruritus that is horrible in some dialysis patients could actually be the reason why these patients cannot sleep properly. Now, the sexual dysfunction. Well, actually, the systematic review of about 8,343 patients said that the prevalence of erectile dysfunction in patients was 75%. While in females, it was a much smaller number, only 138 female in this study. The prevalence was almost 30%. And usually in both categories, it was more associated in patients who are older, who have diabetes mellitus, and common sense who have depression. Still, it was improved that in males, the issues were improved if they used the phosphodiesterase 5 inhibitors, and also if they used oral zinc supplements, but not improved if we did add zinc to the dialysate. While actually to the females there were no proper solution presented, and there is a huge discrepancy between the papers studying this complication in males compared to females. So female studies should be done in our region, because actually in the world, because they are very, very scarce, in particular regarding sexual dysfunction. So now, having talked about all these psychological issues, there are very important angles that I would like to consider, which is actually many of the psychological issues were better if the patient was provided a longer duration of dialysis, in particular nocturnal dialysis. It was found that nocturnal dialysis, particularly PD, improved to a great extent the level of psychological complaints, because it was said that patients who dialyze only during night, they have their days, they have fewer dietary restrictions, they can lower the need for phosphate binders, and they have no recovery time after treatment. So according to many studies, PD was better. And this study presented by Chinese hospital, actually it was done during the COVID period. Well, they stated that hemodialysis patients had poor quality of life, while they also had more suicidal tendencies and sleep problems during the COVID time. While actually PD patients during COVID had better physical and mental health conditions, they had better quality of life, and they had less depression. They said that it was, in general, PD provided a better psychological state because actually many of these patients had more autonomy. They weren't relying on a hemodialysis center which was available or not. They could decide their own fate. So they state that this was the major reason why these patients were much better regarding psychological issues in comparison to hemodialysis. Another angle which is very important to actually consider is the effect of hemodialysis not only on the patient, on his family and friends, because having a person in the family on dialysis affects actually negatively the health of the caregivers. It was found that 30 to 50% of the caregivers were actually complaining of anxiety and depression in this study. I didn't mention it, but also we found studies where it affected also the health workers. Even the nurses in dialysis units were found to have higher complaints of depression and anxiety due to the fact that they are seeing patients getting attached to them, some of them dying in front of them. So this is also a very important aspect to consider. So what can we do? What is the management of potential, and what are the potential psychological interventions to provide to these patients? In this very interesting paper, actually, the first thing is that we have to work with a psychologist, because psychologists can use the questionnaire to actually assess many aspects of psychological diseases. And once he can assess, we can try to use many different interventions. They could use spiritual therapy, peer group supports, CBT, etc., to try to deal with the issues. And it's also important to know when we need to have a psychiatrist, because then when you have serious psychiatric diseases, we have lots of suicidal tendencies, then we will have to also to see and to try to use antidepressants and other therapies to try to deal with these serious psychiatric issues. And I liked this paper when I saw it, that the sense of humor and survival in patients with end-stage renal failure, they found that actually if patient has a higher sense of humor, this actually improved their coping to their condition, and it affected and protected them from the very detrimental effects of the disease-related stressors. And actually, how can we try to make it happen? They found that laughter and humor therapy in dialysis, like what they say, like laughter yoga, if you have heard about it, which combines deep breathing, prolonged stimulated laughter, and natural laughter, has been found actually to improve the outcomes of many patients on dialysis. It was found that in this center where they were having regular laughter yoga, or using, for example, videos in the dialysis center, or funny movies, or having like a clown coming and performing in the center of dialysis, that the fact that these patients were laughing more frequently, it diminished the depression, the anxiety, their pain, improved their immunity, diminished fatigue, improved sleep quality, respiratory function. So again, just having laugh and having a good positive energy around could help the patient cope with their problem. But then someone will tell me, okay, so do we have an insurance company funding for laughter yoga? I don't think that this is something we can provide. So again, what we can try to do is maybe going for the easier and more accessible way, which is actually exercise, because exercise has many benefits we all know about. We've mentioned fatigue, it affects the mood, it affects a lot of psychological issues in these patients. And that's why, again, like having a psychologist in the dialysis center, having a psychiatrist whenever needed, and having a sport physiotherapist is very important to try to educate the patients that not because they are sick or on dialysis that they should stop moving. On the contrary, their movement during the dialysis and between dialysis sessions could actually give them a longer life, diminish sarcopenia, and give them their psychological conditions. Another angle which is very important, that we have also social, political, and legal support which is supposed to be provided to dialysis patients. In this very, very interesting paper with lots of beautiful women, Valerie, Sabine, Priti, and Urmila, they were trying to see the social, political, and legal determinants of the kidney health. And I mean, we know that first thing, if we have a good healthcare provision with a good healthcare coverage and insurance, of course, it will give these patients a good psychological support, that they are covered, that if they are sick, they will be supported by the healthcare in their countries. Education, as I mentioned, that if you are educated, you know how to prevent illness, and in case you have your illness, how to deal with it and how to cope with it properly. Social and community contexts, where actually we have ways to support women, for example, who have children and who don't know how to take care of them during dialysis. So this is very important, and it would reduce the level of stress and psychological issues to many patients. Economic stability, again, if it's important to have a good job security to provide to these patient potential works to feel that they are efficient and part of the society, medical care and food availability. And of course, political and legal factors, again, regarding the government policies for dialysis and transplantation, where we know that some don't even provide subsidization for dialysis. So what could be worse than that? So again, governments would help to support the well-being of patients in general. And if we look, why do we need to support? Because if you look at the WHO definition of a disabled person, and actually you will see that in part of these criteria, you have a patient who has mobility issues or mental health issues is considered a person with disability. So now we are acknowledging mental health as a disability, and that's why there should be a proper care and support from organizations, global or international, to our actually patients on dialysis, because they have lots of disability as a consequence of dialysis. So what is our target when we're trying to treat these patients? We're trying to help these patients to live well with kidney disease by dealing by all these different strategies, and very important, their psychological status. So thank you all for your attendance. And what are now my final recommendations and conclusions? It's very important for us in the clinics to properly prepare patients for transition to hemodialysis in the late stage of end-stage kidney disease, because this could actually make a big difference in the acceptance of the patient of his fate. It should be part of our regular practice in our clinics. Also, we should include in the dialysis units routine psychological tools, actually to be added to the regular biological follow-up guidelines. What is the use of having an adjusted calcium and phosphorus and hemoglobin in a patient who has depression and who has suicidal thoughts? It's very important to assess psychological condition of our patients. Also, we should have training programs to help to detect early psychiatric illnesses and to initiate early treatment before having serious consequences. We need social support in the form of creating suitable job opportunities. Patients on hemodialysis who work are much better than those who are unemployed, which are actually the majority. And also women family duty support is very important. We should encourage physical activity and maybe laughter yoga, because these can help diminish depression, fatigue, and sleep disorders. PD. I am a strong advocate for PD, as you all know, and especially when know that PD actually could help in diminishing psychological burdens. So please, let's try to support and advocate more PD. We need more studies and researches. We need it in Africa. We need it in the world. We need to look at the patient not just as a body, but also as a soul, and to see what's happening in their emotions and in their heads. So what my conclusion and recommendations are, I mean, I love this drawing, which is saying that in the game of life, death always wins. We know that we are all going to die. So all we can do is to choose how to play. And this is especially true for patients on dialysis, because they know that they will die soon. And what we have been trying to do with all our studies and all our medications is trying to add years to the life of the patient on dialysis. We're trying to make them live longer. But actually, what has happened is that actually we failed to do that. So at least what we might be trying to do is adding life to years to let them live better. So at least improving the quality of life of these patients while they are on hemodialysis maybe could be more important than trying to make them live 1 or 2 years more. And thank you all for your attendance.
Thank you so much, Prof, for your wonderful talk, as always. This is greatly appreciated. Maybe if I can just ask you a question before we go to the panelists and the audience. So I did see that you mentioned one of the treatment was to prolong or increase the amount of dialysis that patients get. Would transplantation be an option as well if it is easily accessible as part of treatment?
I mean, of course, transplantation is the best way to deal with end-stage kidney disease. We might talk about dialysis until tomorrow, but a state is that it is the best alternative for these patients. So transplantation, of course, I mean, I was giving a talk today about how to adjust the weight of the patients post-transplant. And one of the main reasons why patients gain weight is because they are happy. They are in a better state. They have increased appetite. They have less catabolism. So of course, transplantation is the best option, and that's what we should be targeting as number one. I would say number one is prevention. I don't want to have kidney diseases. Number two is if they have these diseases, to slow the progression. Three, if they're end-stage disease, transplantation. Four, if they're going to dialyze, I would say PD first policy for those who actually are suitable candidates, and then hemodialysis on the bottom of these choices.
Thank you, Prof. We have a couple of questions from the panelists. Prof. Naika, would you like to speak? You can unmute yourself.
Thank you very much. Thank you, Rasha. Wonderful talk. I enjoyed it immensely.
Thank you.
I just wanted to make some comments and get your insights. There's no doubt that CKD really impacts on all facets of our patients' lives and their families and their caregivers. And in a lot of instances, one of the things I found is that, for instance, women particularly were vulnerable in that their marriages broke up. Whereas I don't want to sound sexist, but certainly when men had kidney failure, the wives didn't abandon them as readily as men abandoned their wives who had kidney failure. So that's just a sort of subjective observation that I've made. And also what you've mentioned about PD, there's no doubt that PD does give better quality of life by improving all the biochemical and physical criteria in a really well dialyzed PD patients. But one of the things we found was that, you often got patients who were really depressed, especially the younger patients. And the PD first policy then wasn't so good for them because they needed that psychological energy to do a good PD. In that instance, maybe they would benefit by a period of hemo until they got themselves together. So having said this, the point I want to make is that we need to provide holistic care. But because a lot of us are working in low resource centers, it's actually very, very difficult to address, all aspects of care, the psychological components, the supportive care from the social worker, the legal. And even when you read the literature from high resource centers, like the US and Europe, it doesn't look like they're dealing with these aspects of supportive care very well. So having said that, what I would like is your insights as to how we could handle this in Africa, because there just aren't enough doctors, enough nurses, enough dialysis personnel to provide this sort of holistic care. But it's very, very important, and we need to do something about it. And I must say that I'm full of admiration of all the patients that I've known on dialysis. I've really been full of admiration as to how they've coped with really adverse social circumstances and did dialysis for many, many years, very bravely and very well. Thank you.
Thank you, Dr. Sarar, for your beautiful comment, as usual. I would first answer a question regarding the inequality regarding males and females in diseases. I mean, it's a number that we have seen even in transplantation, that females in general are born as caregivers and more generous in general, being taking care of their families. And it was even reflected in kidney transplantation, where most of the donors globally regarding the kidneys are females, and the bigger number of recipients are males. So it's a nature that God created in females. And unfortunately, it reflects also in diseases where they could carry for someone who's sick, but it doesn't really necessarily happen vice versa. That's why the social care, as you mentioned, is important. And one of the things which I think we are more or less lucky in our region is that we still have family values. I mean, it is a huge issue in some Western societies where even elderlies, whenever they reach a specific age, they're put into homes, and when the family don't have time to take care. But I believe we still have that within our continent and our societies, where family take care of each other and they support them. And this is huge. The family care is huge regarding support, financial and emotional and psychological. So this is what maybe we can try to do. Maybe also using holistic care, using religious groups, holistic groups, churches, mosques, whatever the belief is, to try to find individuals who are willing to donate their time and their energy to support this would be very important. I think it's more an issue of organization. Once you have organization, people do support each other. The better solution would be, of course, to have governmental support and to have good financial support, but we are still a few steps away from having that in our society. So I think we should rely on ourselves to have society support. This is what I believe is very important. Regarding a question about PD first policy, I agree, of course, but PD, especially nocturnal PD, provides to many of the young individuals who dialyze freedom of doing things during the day, to study, to work. I mean, I've seen this Tunisian teacher who did actually manage to have her PhD while she was on peritoneal dialysis. And at the end, she managed to get a transplantation. So she was a beautiful story of a patient who was on PD, who didn't stop working or actually educating herself. And at the end, she had transplantation. But if we look at the best scenario, what was done in Spain is PD first policy. They stay on PD while being on a waiting list for transplantation. They stay for 1, 2, 3 years maximum because they have a very strong cadaveric transplantation program. So all patients are on PD. They are on the waiting list. They dialyze within 2 to 3 years with the preservation of their kidney functions, and they are transplanted. So maybe this is a dream. If you manage to do that, this was proved to provide the best psychological and physical outcome for our patients.
Thank you, Prof, for the great question and the great response. I believe holistic kidney care is something that we dream about, and hopefully one day we will be able to provide it for our patients. I believe that perhaps if this is something that can be integrated in the curriculum for doctors, for nurses, for assistants, for dialysis techs, I mean, the more the merrier. In that way, we'll be able to target, the holistic care in multifacets. So I think this is something that perhaps, is something food for thought for the academics out there. Amar, I see you have a bit of a long question. If you don't mind, maybe you can unmute and ask the question. Maybe if I can, maybe he's got a bit of an issue with his mic. So Dr. Amar is a nephrologist based in Dar es Salaam. He is thanking you for your presentation, and he says that in short and long-term hemodialysis patients, how do we navigate the relationship between illness perception and psychological resilience, particularly when adaptive coping mechanisms such as denial initially serve protective roles, but rather evolve into barriers against treatment, adherence, and quality of life? In the context of palliative care for families of hemodialysis patients, one of our greatest challenges is helping relatives transition from curative mindset to an acceptance framework, not through disappointment and despair, but through understanding that preparing for the worst does not mean giving up hope. So I
Wow,
believe there's a
what a
question and
what a
a
question.
comment. Yes.
Yes.
Yeah.
I love the comment, yes. And I would just answer, I comment on, with two words, early intervention and preparation. I mean, it's very important to know what to expect, to talk to patients while they're still in the clinics before they reach dialysis. It's very important to be frank, to tell them what they are facing and the positive and negative parts. So being honest, talking early usually helps prevent. And trying to detect the early signs is very important. I mean, that's why educating, as you said, nurses, doctors in dialysis centers, they are the most close to our patients. Having the questionnaire, if you don't have a psychologist, having the questionnaire, seeing that there are changes happening with the patients on dialysis, using it to assess and to have a number. We have numbers for labs, we don't have numbers for their psychological status. Being able to detect that and to take action early, I think, is the best thing that we can give to these patients.
Thank you, Prof. One more question from Oprah. She says dialysis patients often struggle emotionally with long-term treatment. What are some simple things we can do as healthcare providers during our daily interactions to help them feel more supported psychologically?
I mean, of course, let's take a few steps back. Providing a proper care during dialysis. I mean, care, being there, doing the labs, examining them, listening to their complaints. This, of course, will make them feel that they are seen. It's very important. And maybe there are these activities which are provided at some dialysis centers where there is an outing for all dialysis patients. Let's spend a day when all of you, let's go and spend a day in the outdoors. Let's have a context for physical activity with the different ages. Let's have a book reading club in the dialysis session. Having these kind of activities, having movies which are funny, like I said, within the dialysis, all these things which might not be very expensive, might give them a sense of community, a sense of belonging, and a feeling that they are alive. It might help.
Thanks, Prof. I'm not sure if there are any more questions, perhaps any more questions from the panelists or any questions from the attendees.
Maybe I could just comment on Rasha's last comment. One of the things that I found very helpful is that I got together a few of the more proactive patients, and they formed a kidney patients club for exactly that reason that you mentioned, Rasha. They organized talks from psychologists, from social worker, from the physiotherapists. They arranged outings. And then we as a unit organized sort of huge parties, twice a year or so
Wow.
for everybody, staff, patients, and whatever. In the beginning, the patients felt very guilty, like they're not supposed to eat in front of me. I said, no, I'm not here auditing food and drink. Just enjoy yourselves. You know what you're supposed to eat and drink. I'm not checking. So we actually used to have wonderful times, so you got to know the patients and the families very well because we opened it to families as well. So, but as I said, we basically, for the general sort of monthly activities, the patients ran it themselves. And it was just superb, what they did for themselves. And it actually helped them to cope better.
So maybe you can give us a presentation about your experience, Prof. Sarala. I would love to hear about the details and
yes,
pictures.
absolutely.
Yeah, it would be
Yes,
beautiful.
absolutely.
Very inspiring. Thank you. Thank you so much.
All right. Thank you, Prof. And thank you, Prof. Rasha. I believe there are no more questions, and I know that you are at a conference, and I need to jump off and go into the transplantation course.
Yes.
So I
At the
will.
same time.
I will let. Yes. I'll let you go. I would like to thank you again for coming on to the Fireside Chat. It's always a pleasure to have you, and thank you very much for your insightful presentation. It's great, as you can see, the engagement, and for